Okay. Yeah, good evening, friends. Welcome back to our Weekend with a Maestro program, our episode 8 of Weekend with a Maestro program. See, we are celebrating two events actually. One is International Cochlear Implant Day, the other one is World Hearing Day. So, on the occasion of this event, we have organized this special topic that is cochlear implantation by facial recess method. Okay, thank you all for joining this event. And we have to follow some meeting etiquettes like all other meetings. So, my request is to please mute your audio so that we can have a seamless program and no disturbance at all. And if you have query, please raise your hand whenever you have a query. Okay, don't hesitate at all. You can stop me or the faculty who is very kind person, very sweet person. So you can stop in the between and ask any questions. And also you can use the chat box for asking questions. Either you can ask me directly or the faculty directly and clarify your doubts. Of course, in the end, again, we are going to have a final discussion and you can discuss again at the end of the event also. Okay, and we have no personal or financial conflict of interest this event concerned. Our sponsors are Basaveshwara Medical College and Hospital, Chitradurga, Karnataka ENT Hospital and Research Center, Chitradurga, and Champions Educational and Medical Society, Chitradurga. Okay, and I want to give an introduction about our next program, that is Weekend with Maestro episode 9. Okay, that will be held on the 6th March 2022 on Sunday from 6 to 8 p.m. And the topic will be optic nerve decompression for traumatic optic neuropathy. Okay, with this, friends, I would like to introduce my friend, a well-wisher and a kind of mentor. Sorry, there is a mistake name I didn't change in the sales side. That is Dr. Deepak Dalmia, sir. Okay, I'll tell you one thing. He's such a sweet person. I don't know how God makes such a sweet person as Dr. Deepak Dalmia, sir. Sir, welcome to our event.
Thank you.
Why you are so sweet? Is it a congenital abnormality or?
You ask my students, then you will know that I am sweet or bitter.
Anyway, you need to be bitter once in a while with the students, because if you want to teach, you have to show all of emotions. I know the sir is a senior consultant, head of the department at Baba Ambedkar Railway Central Zone Hospital in Mumbai. He is holding a very important position. Sir, I want to know all the participants want to know your journey, like where you started your undergraduate education, how you reached DNT, and how you reach where you are today in this position. Please share. We want to hear from your mouth.
Yes, hello friends. Actually, Prahlad asked me the right thing, because my journey is just about teaching, learning, I can say, because in 1999, I passed my MS from Jabalpur Medical College, Madhya Pradesh, Government Medical College, Jabalpur. Then I passed UPSC and I got this job at the Central Railway Hospital. It is a zonal hospital of Central Railways. And I joined here as an ENT surgeon. It is a very well-equipped hospital. Then I started working here. And after finishing my work at 4 p.m., I used to go to all the big surgeons or the famous surgeons or renowned surgeons of Mumbai, from Dr. Kirtane to Dr. A.B.R. Desai, Dr. Pusalkar, Dr. Morwani at Tata Hospital. All the places I used to go, even when we were on call, we were getting next day off. So I was with one of the surgeons out of these 4, 5 I named, to observe them. Even after finishing my OPD at our hospital, I used to call Hinduja Hospital and ask the clinical, my friend Dr. Rajiv Pachori was working there that time. I used to ask him how many cases left, Rajiv. Then he was telling me 2 cases. Then I went there and observed sir doing endoscopic sinus surgery. Then I observed Morwani sir, attended his workshops, hands-on dissection courses. I observed Dr. Pusalkar. When I use side knife, I always, Dr. Pusalkar comes in my mind when I use side knife while raising the tympanomeatry flap. This is the way I learned from I went to Dr. A.B.R. Desai and I asked him, sir, I want to learn from you. I heard a lot about you. Why, what is the difference? Why you are so famous, otologist of at least India, abroad also? So he said, okay, then I started going there. After finishing my OPD, I worked with him as a clinical assistant. And the things which I learned in otology from him, I always remember. And what I say about Professor A.B.R. Desai means you can write a book on him. He is such a great otologist. And I always felt that now he's no more with us. Last month only he passed away. But I always feel if you want to be a good otologist, you must have worked with Professor Desai. He's such a great surgeon. And I learned from him, like in his steppies, I learned how you measure the length of the piston, hanging test, bending test. This I learned from him. And use of ball probe. Whenever I do adhesive otitis media case, I always remember Dr. Morwani sir. He used to say, increase the magnification of the microscope and then use that ball probe and you will find a plane between the adherent drum and the promontory mucosa. Dr. Kirtane, I learned cochlear implant from him. I used to go to him to observe him. And then after observing him, when I leave from his hospital at Kambala Hills at Camps Corner, I asked my junior, induce the case, now I am coming. After observing him cochlear implant, and after half an hour of finishing his surgery, I was performing cochlear implant at our hospital. This is the way I learned from all great surgeons. Even the head and neck from Tata. I worked with so many head and neck surgeons. And then I observed him and then I always feel, today only I was telling, if you have good eyes to observe how the surgeon is handling instrument, how he is performing that step, then you will learn only. This is the best way. Observation means spoon feeding, I don't feel is the right way to teach. Observation is the best way to learn.
Yeah, I think that's a great lesson you're given, sir. 2 points I really take home messages we have to start with. One is, spend your time rightly. Whatever spare time you get, you go and observe these great surgeons. I think that's a great message you're given to start with, to begin with. And the second thing is, observe their hands, how they do it. I think this is something, every surgeon, every junior surgeon should follow. There are lot of intricacies involved in surgery. Unless you observe those minute, the steps, you won't understand it. I think that's a great message, sir. I think that's a very humble beginning you had, and you candidly shared it. Thank you very much for that, sir. With this, friends, I told you about the meeting etiquette, and I've introduced you. Let the show begin. You can share your presentation, sir. Yeah.
Okay. Thank you.
Yeah.
Thank you for the nice introduction.
Yes, sir.
Dr. Prahlad, and thank you for giving me this opportunity to share my experience on cochlear implant.
No, sir. You are a legend. It's our privilege and our honor to have you here. Yeah. Please share your screen, sir.
Again, it is okay. Okay.
Yeah.
Can you see my screen?
Not yet. Not yet. We are waiting.
But why?
You opened your PowerPoint presentation? First, open the PowerPoint presentation, sir.
Yes.
After that, go to share screen.
Yes.
Yes, it's coming. Perfect.
Now?
Yeah.
Okay.
We can see. Clear. Yeah, you put some animation there. Click once. Went out.
I don't know why it is going. You connect my hard disk on this. I think this is because of this problem. No, it is again opening. I'm sorry, all these.
No, it's okay. It's okay. No, we have these technical issues once in a while. Yeah.
Internet is unstable. It is going again and again. This is not a good thing. तेरे उसमें खुला हुआ है? I don't know why it is shutting again and again when I start sharing.
Yes.
Can you see now?
Maybe the file is too big. Sometimes happens, sir. Try playing. Let's see.
Okay. Yes. Can you see now?
Yes, sir. Perfect.
Okay.
Yeah.
So thank you once again, Dr. Prahlad. And I'm going to talk on avoiding complications or failures in cochlear implant surgery.
Okay, sir.
Okay. And my mentor, as I said, Padma Shri Dr. Professor M.V. Kirtne, sir.
Yes, sir.
Avoiding failures and cochlear implant surgery. And I'm going to present you a straightforward case of cochlear implant operation by transmastoid facial recess route.
Yes, sir.
In just brief, I will tell you, I know we all know about the parts of the cochlear implant, but these are the two parts, the external speech processor and internal part which we implant under the skin.
Yes, sir.
To the postural root. This is the internal part and this is the external part. Both parts are having the magnet.
Yes,
you
sir.
can see this is magnet, so that because of this magnet they work and as an assembly.
Yes, sir.
Now, for cochlear implant, the most important is anesthetic issues are very important because little children's their physiology is uniquely different from that of adults.
Yes, sir.
And their homeostatic mechanism are more vulnerable than adults.
Yes.
Their reaction to anesthetic agents and other drugs may be unpredictable and sudden.
Yes, sir.
They usually handle the blood loss of surgery less well than adults, and they often have pulmonary problems. So
yes.
These are the issues. Anesthetic issues are, I always feel, are more challenging than the surgery.
Yes, sir.
We always need a good anesthetist with us.
Mm-hmm. Yes, sir.
This is the position of the patient.
Yes.
First, what we do, the position of the patient. The patient is positioned in the supine position.
Mm-hmm.
The head little extended. Here you see, this is the head is so that this ear become little bit oblique.
Yes.
Okay. Can I hide these names, Dr. Prahlad? Okay, minimize.
It's okay. It's okay.
Yes, yes, it is. So you see, this is the speech processor is going to come here. This is the position of this speech processor is very important for planning the incision. Before that, because of this slight extension and putting a small pillow under the shoulder, this position of the ear is very important. And this position we do in all our ear cases.
Okay.
Little extension of the head, so that we will get a better exposure of the posterior superior region.
Okay.
If we do steppies, then also we keep this patient like this.
Okay.
Okay. Why it is not going? Okay.
Yeah.
Now you see what the placement of the speech processor, planning of this is the receiver stimulator or the internal component.
Yeah.
This is the speech processor will come like this.
Okay.
And this positioning, marking of this position is very important because these two things, the internal component and this external component, this is internal component and this is external component, they will not overlap each other. Okay. So this planning is very important. So a horizontal line is projected backward. Here, the video is not playing. I don't know. This horizontal line is projected backward and will go along the superior canal wall.
Yes, sir.
Okay, this line
Mhm.
backward. And I will try to show you. And this receiver stimulator should come above this line. Otherwise, what will happen if this will go down here?
Yes.
Then when the child sleeps or when lie down, this will again and again this will misplace this speech processor. So this line should be above this speech processor.
Okay.
And the position of the external component is, as I said, is determined by the position of the internal component.
Okay.
I will try to show you this video if it will work. No. No.
Probably video is not there on the computer.
No, it was playing here. Now I don't know why.
Insufficient disk space. Your hard disk is full, sir. Yeah.
Okay. So all the videos will be like this?
We'll see. Okay.
Now you see the infection part.
Yeah.
We have to properly scrub the area because infection is the enemy of the implant surgeon.
Yes.
Careful, thorough, extreme attention to asepsis is essential. So you from the lateral canthus of the eye up to the corner of the mouth and whole neck up to the clavicle, then occipital region, you must scrub all this area.
Okay.
Meticulous skin preparation is essential to minimize the risk of infection.
Okay.
Infected foreign body is a disaster and nearly always leads to explantation of the expensive device. So after doing this, allow this to dry so that it will be more effective. Then you use this, after draping, use this steri drap to position this. This will curl forward.
Okay.
Then after doing, and the imaging, as we all know, plays a very important role in the pre-operative planning. And the pre-operative assessment by HRCT and MRI is very important. This gives us the idea about the cochlear morphology. How is the cochlea? This is all you 3 terms you can see in this normal oculovestibular structures. Degree of aeration of the mastoid is very important because then you will get the idea whether the sigmoid sinus is, and here you can see the sigmoid sinus, whether it is antipose or in normal. So here it is a very well pneumatized area. Then the presence of air cells around the facial recess. Here you see, this is the facial nerve.
Yes, sir.
And this area, and this is the tympanic annulus. So this area is very well aerated. And this one cell is taking us in the middle ear.
The
annulus, and this is facial recess. And this one cell is taking in the middle ear. This is the Herald cell or the in predicting the extent of drilling of round window is again very important. How much drilling is required of this round window niche? We have to drill to get proper exposure. Then we will do, I will show you in the coming slides, even the jugular bulb, height of the jugular bulb. What we say, the overriding jugular bulb is the term when we use when this jugular bulb covers the promontory or reaches up to the promontory and covers the round window area. That is very rare. And this is the MRI showing the cochlear and the vestibular nerve. And these 4 nerves we can see in the coronal cuts. Reconstructed. Then, as I said, the aeration of mastoid is very important because in the diploic mastoid, you have to be very careful to avoid injury to the sigmoid sinus.
You are right. Perfect.
Then the position of the round window overhang can be assessed by the consecutive axial cuts from above downwards. This also you have to assess so that this is the round window area and this is the niche area. So this also you can see and keep in mind while performing and the pre-operative assessment by imaging while performing the surgery.
Yes, sir.
Now, after positioning of the patient, scrubbing the patient, then reassess the imaging while starting the surgery. Then we go for the incision. And now we give this now C-shaped incision. In the beginning, we used to give this lazy S-shaped incision. Now we only give this C-shaped incision because what we observed, that sometimes this lazy S-shaped incision and this anterior edge of the receiver stimulator it may come. So what we started doing here, you can see this is receiver stimulator is exposed here. So what we started doing, we give this only C-shaped incision. So even this limb will not come in here. Closer. In spite of taking so much of care and measurements, these things may happen. So you should be again and again. You have to again. Yeah, these videos are not playing. This is not right, boss. I have to. Can I show from? Can I show from Dr. Riju's?
If he has opened, we can open the presentation in that thing.
Just if this will not work, then what is?
That video is very important for us.
All the steps are having video actually.
Yes. Now,
in between you can share your.
No, what we'll do is, so what is your colleague's name, student's name?
No, but he is not having, no.
No, Riju, he is.
Riju, I said, but he connected the hard disk with mine.
Okay. You can disconnect with this. So I will make him
try with my hard disk. Just a minute. I will see whether this is opening in my hard disk or not. Can you see my now?
Yeah, it is there. It is there.
Yes, I will see whether it is opening in this or not. Why it is happening like this?
No, that is because of less space on your disk, hard disk.
Hard disk.
Your laptop hard disk, computer or laptop hard disk.
That I can delete some immediately. That will help.
I am not sure. I don't want you to delete some important things. Or you can if you want, you can play from Rijul Goyal's hard disk also, if that presentation is there on that videos.
क्यों? तो उससे क्या होगा? हमारा presentation कहाँ है? तो तू करना इसमें login.
Is your presentation and video are on hard disk, sir?
Yes.
You can do one thing.
All my presentation, the files are incorporated in that, means video files.
Okay, they are together in a
and it was working. I don't know why it is not running now.
Portable hard disk or your laptop hard disk?
कौन सा पासवर्ड? डी कैपिटल से DEE बाकी की चीज स्मॉल से @ Sorry, brother.
No. We want to have you other things, sir.
क्या हो रहा है? देखो मैंने कहा था ना उधर चला के रखना हमें क्या खराब है ये सब देखो कहाँ है पुलिस चला। Actually, I have to ask you now all these points. Ki now it is going on. Can you see now my share screen sharing? Now you can see. Can you see?
Not it, not it. You have to share.
Sorry?
You have to share the presentation.
Okay.
You have to share the presentation.
इसको minimize कैसे करूँ? Okay. Share screen पूछ रहे हैं तो किया.
Yes, it's coming.
Okay. Let's hope the video will work. Yes. Now you see, this is the marking from the lateral
yes,
along the superior canal wall.
Very good.
Okay.
Yes.
And then at 90 degree, we draw this line.
Yeah.
And this is about 3.5 centimeters. This anterior edge of the internal component is about 3.5 centimeters from the posterior canal wall.
Yes.
Okay. This is the internal component will come here. Then we use methylene blue for getting the inside impression of the exact level of the anterior edge of the receiver stimulator.
Okay. Yes, sir.
You can see. This I already said. Then we discuss about the, in brief, actually this itself is a very big topic to assess the imaging and various cochlear malformation. And here you see, this is the way we give this incision going along the post-oral groove.
Yeah.
Up to the mastoid tip.
Okay.
And at every step, you achieve the hemostasis.
Yes.
Using the bipolar cautery or monopolar cautery. Then we raise these flaps, anterior and posterior flaps.
Okay.
And here you see the below is the temporalis fascia. This is the area where the temporalis fascia will come.
Yes, sir.
And this is the anterior flap we are raising. And here you go up to the posterior canal wall. You feel, palpate the posterior canal wall here. This is the soft tissue we are harvesting in the beginning only. And we will keep this in the normal saline. Because after putting the implant to seal that cochleostomy site or the round window area, if we harvest this tissue in the end and we already kept that implant, then if the bleeding starts, it is not right to use the cautery. So we harvest this soft tissue in the beginning of the surgery. Okay. We gave this incision, then raise these two flaps. And here you can see this is just the closer picture. We apply subcuticular stitches, interrupted. No skin stitch. So no need to take out the stitches.
Okay.
Because majority of our patients are children. So otherwise, they will again create problem while taking out the stitches, or we have to take in OT. We even give subcuticular stitches. Now, even on all ear cases, we don't give skin stitches.
Okay.
Yes, subcuticular interrupted stitches we give like this, even tympanoplasty, mastoid and all.
Okay.
Yes, and this is in place of this S-shaped incision, we give the C-shaped incision.
Shaped incision. Okay.
Now it is. Then after giving this incision, the musculoperiosteal incision must be at a different level than the skin incision, about a centimeter anterior.
Yes, sir.
So we started from the temporal region. This is the right ear of the patient, temporal region. Then we go along the posterior canal wall. We feel here the dip of the posterior internal auditory meatus, and then at the mastoid tip, we curve this incision.
Okay.
And this is up to bone deep. Then we use this plaster elevator, and here at the mastoid tip area, these are tightly adherent. So we are using cautery here. The muscle is tightly adherent.
Okay.
Now we creating this musculoperiosteal pocket for the internal component or the receiver stimulator of the cochlear implant.
Yes, sir.
And if suppose here the emissary vein comes, suppose if here the emissary vein comes, which usually you can assess the emissary vein also in the preoperative imaging, what is the location of the emissary vein.
Yeah,
if it
you're right.
starts losing, then you can use the monopolar cautery, you can use bone wax, you can use Surgicel.
Yes.
Anything you can use.
Yeah.
Okay, to achieve the hemostasis. Then in place of applying the retractors here, we use these stay sutures for retracting, because what we feel that putting the prongs of the retractors sometimes may perforate these musculoperiosteal flap. So that is not right. That may expose the internal component. So we use stay sutures in place of applying the retractor.
Okay.
These are the care we take. As I said, my topic is only avoiding complications in cochlear implant surgery. So these are the things we take care while performing the surgery. And this is the posterior-superiorly based flap. This incision from the temporal region along the posterior canal wall up to the mastoid tip, then coming like this. Okay? And
yes,
this
sir.
is posterior-superiorly based. Then again, you have to decide, this is the posterior canal wall here. This is the temporal line. And here you mark this triangle and we say the triangle of attack.
Yes, sir.
And we open the mastoid antrum. Up to this step, doing this step I usually prefer to do without microscope. As such, there is no need to use the microscope.
Okay.
And just looking for the short process of incus, then you can start using the microscope.
Okay.
Because that is a very important landmark. And no need to do over cortical mastoidectomy. Means you have to do even nowadays, I started performing even removing, I am not removing this edge also of the bone.
Okay.
Because we have to work here. The important thing is overhanging edges of the mastoid, so that it can accommodate the electrodes and they will not touch the musculoperiosteal flap. Okay, because in sometimes, I will tell you in the coming slide. So overhanging edges of the mastoid, removing the mastoid air cells from this mastoid tip area also is very important, because this gives us the angle to work in the facial recess.
Okay.
So this removing the cells from here is very important.
Okay.
Then after doing this, we identified the short process of incus and the difference, how you identify. Sometimes the bone you feel it looks like the short process, but the difference, how you differentiate between the bone and the short process, because the incus is mobile. So if you touch with the instrument, it moves. But if it is bone, then it will not move. So this is the way you can confirm whether you reach to the incus or not.
Excellent tip, sir. Yeah.
Okay. Now here you see the facial recess is wider in this area towards the fossa incutis.
Yes, sir.
So start drilling from this area. And then you delineate the facial nerve and the chorda tympani nerve.
Yeah.
And here at the chordofacial junction, this area is narrower.
Yeah.
So you have to work more in this area to avoid injury to the chorda tympani and the facial nerve. And
Yes,
use
sir.
larger size burr and preferably diamond burr
Yeah.
towards the fossa into this area.
Okay.
Lot of irrigation, even the thermal injury may occur. So
Yes,
lot
sir.
of irrigation is very important. Here you see, this is the chorda tympani nerve is going like this.
Yeah.
The facial, and this is the round window niche area.
Mm-hmm.
This, as I said, we can judge pre-operatively, and this niche we have to drill out.
Yes, sir.
Posterior superior, superior, anterior superior. After
Yes,
drilling this, then what we do after drilling this, we keep a piece of gel foam here.
Okay.
We finish our receiver stimulator or well for the receiver stimulator work.
Okay.
Then we will come back again. By the time it become more decongested, then we drilling this area before making the well, but drilling the crista area is I do after finishing my all other work.
Okay.
Making the well and everything, because if we drill here and if this scala tympani opens, then it will remain open for 15-20 minutes or half an hour till we make the well and all these things. So I avoid this step till the placement of the implant and everything. This I do in the end. So you see, this is again one of, and these fibers are stapedius muscle fibers, not facial nerve.
Okay. Okay.
Sometimes we are confused with these stapedius muscle fibers.
Yeah.
They look like the facial nerve. So perfect posterior tympanotomy with intact tympanic annulus and the posterior canal wall. Annulus here will come. And suppose accidentally, if you damage the tympanic annulus, you please repair that with bone pate or the periosteum, piece of periosteum or perichondrium. Don't use as such. Otherwise, in the follow-up, the patient may come with the cholesteatoma because that area become weak and it may retract. So you have to reconstruct that area immediately if you do damage to the tympanic annulus or the posterior canal wall.
Very important point.
Thinning of the bone overlying the posterior canal wall is very important. Over the chorda tympani, over the facial nerve, mastoid segment of the facial nerve, you have to do this. And then you will be able to perform a proper posterior tympanotomy. And continuous irrigation is very important to avoid thermal injury. This enables optimum surgical access to the round window membrane.
Yes, sir. Very important point. Yeah.
Now you see in this magnified view, this is the round window, stapedius tendon, pyramid, this is the facial nerve, this is stapedius muscle fibers.
Yes. Stapedius fibers are, stapedial fibers are more medial to the facial canal. Facial nerve.
Yes.
Yeah.
Yes. Yeah. It spreads from the pyramid.
Yeah. You're right.
Now you see the window is the intraoperative picture. Okay. Now after doing this, you see we make this well for the receiver bed. So again, here the edges of the well are at right angle, not sloping edges. This should be sharp edges at the well.
Yes.
These tie-down holes we stopped making nowadays. Even we are going to publish a paper that these are not required, tie-down holes. Means if you make proper well with proper edges of the well, snugly fitting well, proper size, snugly fitting well, then there is no need of tying down. And we did more than 100 cases without tying, and luckily or whatever you say, means there is no complication and there is no displacement, no extrusion.
Very important.
So
So you
this is
stopped,
the way
yeah, you stopped
making
putting
the
those
diagonal.
sutures. Yeah.
But actually, nowadays the thinner implants are coming. There is well is not there. No need to make well. But you have to make only the edge. Actually, I was not able to put that picture. Uh, there we make not tie down holes, but we stitch with the mucoperiosteum. We apply stitches to the mucoperiosteum of this posterior superiorly based flap.
Okay.
That I will show in some other presentation. And this is the notch we make for the electrode. And even you can make a tunnel like this also if there is a straight area electrode. But what I observed, if we pass the electrode through this tunnel, then it is a bit difficult to handle the electrodes for insertion. For insertion. That is the reason I stopped making this, and we are using this notch.
Okay.
So in this picture, you can see the well, the channel for the electrode lead, and the posterior tympan.
Okay.
These are various pictures. This is the notch I was talking for the anchoring of the electrode lead. Okay.
Yes, sir. Perfect.
Now you see, here I am drilling the round window niche.
Yeah.
This I do before making the well, but the picture video is here only. But I am using a bigger size burr.
Okay.
So that it will not damage the round window. And here you see this was the picture before drilling, and now you see it is exposing slowly. Now the complete exposure of the round window.
Yes.
This was the picture before drilling the round window. Okay.
Yes, perfect.
Now what we do here again, this is another video. You have to drill this posterior superior aspect. This is also very important to get adequate exposure of the round window membrane. And I always say, like when we perform the steppies surgery, then we remove the adequate posterior superior overhang so that we can handle the piston properly. Like this here, if we remove this niche area properly, and then we can put the electrodes without any hindrance.
Yeah.
So this is besides exposure, during the insertion, we will not face any problem. This is the region we are removing. Otherwise, we can see where we have to do the cochleostomy. When we don't perform cochleostomy, we do extended round window approach or marginal cochleostomy. But separate cochleostomy, we are not performing. Yes.
Okay.
So here you see, I am drilling this crista fenestra area. This is the round window. And here we are drilling this crista fenestra. And if you observe, we have not touched the round window till now. Round window is intact. So we are performing all the bone work, and no blood, no bone dust is going in the scala tympani. The round window is still intact. We are doing
very important point.
Thinning of the crista area, eggshell thinning.
Yes.
And the round window is intact.
Yeah.
Now, as it almost final stage we reached, now you can see it is now little bit one opening is there that we can now use the right angle pick and using the steroid irrigation and no need to do direct suctioning on this side. Now putting the electrodes. Actually, this presentation I made in 2018. Actually, now too much of other ways we improved, but I have to put all these things in the coming presentation.
Okay. So this steroid, you are using the hydrocortisone?
Yes, normal steroid.
Yeah. Okay.
So just after doing the posterior tympanotomy, preparation of boning well and finishing majority of bone work, remove the bone dust and blood by repeated irrigation, switch off cauteries, change of gloves before handling the implant, open the implant box on a separate trolley, place the implant under the periosteal pocket and in the well drill.
Okay.
And after doing all these things, then you drill the inferior lip or crista fenestra of round window, last part of the bone drill.
Okay.
Means after placement of implant, everything we did. Now we drill this part and we remove this, lift the round window membrane. I will show you in this.
Okay.
You see here, this is just as I already showed.
Yeah.
Now you see here, this is actually done. Yes, now you see, after doing this work, now we are lifting this, like how we lift the annulus.
Same way.
From the tympanic membrane from the annulus. This is the round window we are lifting.
Okay. So using a right angle pick.
Yes, 45-degree or right angle.
Yeah.
Or you can pierce the anterior-inferior aspect of the round window membrane with the needle and then you can lift. This is just for orientation. This is stapedius tendon, pyramid, round window membrane. Now putting the electrode. And the insertion speed should be very slow because if even even the literature says that it creates the eddies, waves or something like that. The micro tear may occur in the basilar membrane. So it is safer to insert the electrode slowly.
Okay.
These flaw and these things are used very rarely nowadays because we remove proper this inferior lip of this area.
Okay.
This is another case. Here you see this plunger we use in this implant to insert the electrode. So this is a plunger we are using or applicator, I can say. And here you see this is electrodes are visible here going slowly to this slot.
Yes, sir.
And the initial direction should be downward of the electrode to avoid damage to the basilar membrane and spiral lamina.
Yes, sir.
Majority of patients, this is again the right ear of the patient.
Yeah.
And this ring will sit at the cochleostomy site.
Okay.
Different companies' electrodes are having some features which others are not having.
You're right. Yeah.
You can see this is sitting on the cochleostomy. One ring will go inside and one outside.
Yes, sir. Perfect. So those rings are enough. Still, we have to put some soft tissue.
Yes, actually, I always have some phobia, so I am always overcautious in these things.
I've seen, most of the surgeons putting some soft tissue, this thing I've seen, I observed. Yeah. Just sort of curiosity,
Yes, after putting the electrodes, you can check the stapedial reflex. This is the stapedius muscle.
Yeah.
And this is the electrode in place, the cochleostomy. Now you see, here you have to observe that the contractions of the stapedius muscle while they stimulate. Now, can you see?
Yeah, we can see. So it is for the first time is stapedius muscle is working. Yeah.
Yes. So we have to check all these points. This audiologist checks all these impedance or neural response, audiometry, whatever terminology is there. They do that. We have to check. Then we check again. This is the sealing of the electrodes.
Yes.
Cases of infection of the ear.
Yeah.
And this sealing of the posterior tympanotomy site again is very important all around. So this gives more stability to the electrodes, I can say. And this coiling of the electrodes in the mastoid bowl is very important, and you have to take care that it will not project lateral to the squamous part of the temporal bone.
Yes, very important point.
Behind it, this flap can go here back again.
Yeah, yeah.
And if suppose revision surgery is required, then when we lift this, so it will not come out with the flap. So it will not touch this musculoperiosteal flap in this area.
You are right.
Okay. So these are the various pictures, and after stabilization of the electrodes, we use bone pate also to cover this area. Whatever bone pate we collect while drilling the well. So we cover this with the bone pate at the end. You can see this electrode lead area or this channel we covered with the bone pate.
Okay.
We avoid using bone wax. Then we do the closure with this musculoperiosteal layer. First, with using 40 Vicryl.
Okay.
And this again the subcuticular stitches we apply.
Then
this bandage we don't touch for 5 days.
Okay.
We touch after 5 or 7 days directly.
Okay.
We never see this bandage, and when we remove, the wound almost healed in our patients.
Okay.
I said we are not applying skin stitches. So we open this bandage between 5 to 7 days.
Okay.
If the local patient, then we call after 5 days. If the patient is from outside, then we call after 7 to 10 days actually.
Okay. Okay.
But we ask them just to take out bandage at home after 10 days. If they are not able to come. And you see the picture.
Yeah, hardly any scar. Yeah.
Yes.
Beautiful, sir.
And these are the X-rays. We do CM picture checking also intraoperatively. And these are the of the electrodes. And this is the patient with bilateral implant.
Yeah, fantastic. Fantastic.
This is another ABI implant. This you heard about the Mumbai technique for CI. Just I will tell you in brief. Just what they do. I did in one case just for the recording purpose. I'm telling you. Just see whatever we do. When all these things are. This is just the cortical part, and all these things is same.
Okay.
What we do, just I will tell you the concept of doing this surgery. Some are having the fear of doing this surgery. So after identifying the short process of incus here. Yes. Now, yes. Now, what you do, this short process of incus is here. And 2 millimeters underneath this. This is the lateral semicircular canal will come here. This is the canal wall. Few millimeters medial to this, inferior to this, you use and just make a hole here.
Okay.
And then you lift this posterior canal wall skin from here. And you see the round window from here. You put the electrodes from here and guide the electrodes from the meatal side. But no need to open the external auditory canal. Just you elevate this intact posterior canal wall flap.
Okay.
This will come back again. This is the posterior canal wall. This is the posterior canal wall skin. We will elevate from here.
I got your point.
From here. Yes. So I will show you. This. We made this. This is we made. Now we elevate the skin flap from here.
Okay.
Without doing the meatotomy.
Okay.
I am not doing this surgery. This is just one surgery I did. Just for the recording purpose or demonstration purpose. If somebody asks what is this technique. Even I am not advocating this. Then we raise the flap. And you see, we have not done the meatotomy.
Yes.
And we are elevating the annulus. Now, as we are not able to see the round window, we have to drill this area a little bit. I want to say that whatever way you do, whether Varia or posterior tympanotomy or Mumbai technique or Bhopal technique, the important thing, the outcome.
Okay, okay.
And the less complications. That is the important thing, not the approach what you are doing.
Yes.
This is just thinning. And you see now again I am drilling the round window niche. After exposing the round window area, I am drilling the round window niche area now.
Okay, okay.
Now you can see the round window membrane. Okay. Now I will put the electrodes from here.
Okay.
And it will go. This is the Mumbai technique. If you don't want to do the complete facial recess.
Oh. Okay. But any day I would prefer facial recess than this. Yeah.
No doubt.
Yeah.
Yes. I totally agree with you. Even I don't like this at all. This is just to demonstrate.
Yeah. Okay.
Okay.
Yeah. Perfect.
I hope this cleared all the concepts.
Yeah. Perfect, sir. So what post-operative antibiotics you give? How long you give?
We give only augmentin.
Okay.
As per the weight of the child. And that too for 7 days.
Okay.
And we discharge patient the next day, and oral syrups we start from the next day.
Okay.
And as I said, we don't disturb the bandage. We don't open the bandage. We open after 5 to 7 days.
Okay.
Because at every step we are achieving hemostasis. If you have observed, you are not seeing bleeding in any of the step or
nothing is there.
If you achieve proper hemostasis, then the chances of hematoma or these things are very rare.
Yeah. You're right. Perfect.
So there are a number of reasons why an implant have to be removed and replaced: infection, device failure, non-auditory stimulation, and technical upgrades.
Yeah.
The incidence of major complication in the literature is 3% to 13%. And our aim is to prevent all these complications by taking the care which I said at every step. The operation to insert a cochlear implant is not difficult for the experienced otologist.
Yes.
It does, however, demand meticulous attention to avoid infection, to ensure the correct location of both the receiver stimulator and the electrode area.
Yeah.
As patients with more and more residual hearing are now being considered for implantation, the importance of atraumatic insertion, soft surgery places greater demand on surgical technique.
Yeah. You're right.
Badly performed operation can therefore ruin the whole implant process by failing to ensure a favorable placement of the device, by causing damage to the remaining cochlear structures, or by causing the patient unacceptable complications.
Yeah.
And remember all these points. This is the slide which I put in every presentation.
Yeah.
Decision is more important than incision.
That's right. Very, very important quote. Yeah. Golden words.
Yes.
Yeah.
Yes. Take your time and be precise. Remember that for you, surgery is limited to 60 to 120 minutes or 3 hours, but the result will influence the patient for lifelong.
Yes.
And in unexpected, difficult conditions, it takes more courage to step out from an operation than to continue it.
Yes.
Suppose you are seeing a antepost sigmoid sinus, you are not able to perform the posterior tympanotomy. There is no harm in doing the surgery. Come with your senior and do the operation.
True.
But doing continuously, damaging the facial nerve, damaging the posterior canal wall, or opening the sigmoid sinus, and risking the patient life is not at all acceptable.
You're right.
There is no one best technique to suit all the circumstances.
Yeah.
Thank you.
Yeah. Perfect, sir. Thank you very much for
Actually,
wonderful
just
presentation.
one point I want to show. These are all the children. We conducted one program for all these children who were operated at our hospital. At the end, what we want to see such a smiling child during switch on. Just see this video. Jai Sri Ram. Jai Sri Ram. Jai Sri Ram. Jai Sri Ram.
Wow, what a smile.
Thank you.
What a smile. Yeah. When they smile, we will have tears in our eyes, right?
Yes.
Yeah.
And when they share the parents of the kids, they share videos of the children which we operated during 26th Jan or 15th August or Diwali or Holi.
Yeah.
You feel so good. Yes.
Yeah, you're right. Fantastic, sir. Wonderful presentation. Dr. Deepak Dalmia, sir. Friends, any questions? We have participants, though we have a small participants, but we have a international audience here. Okay. We have friends from UK. I'll see you have friends from Kenya. Okay. So we have and we see friends from Mauritius, of course, India, some of our senior friends. Yeah. Dr. Sarvat from Iraq is asking, may happen to shift to implant other side in certain unfavorable situation in the planned year. Okay. So you started a surgery. Did you have to shift to opposite side anytime? Hello?
No, luckily not. Not luckily not.
Not luckily. Yeah. Some surgeons have shared with me that they had a rotated cochlea or something. They couldn't find the round window. Nisha, they couldn't do a cochleostomy. They switched to the opposite side. I've heard this from 1 or 2 surgeons. Yeah, Dr.
Actually,
Sarvat,
what? Again, then in such situation, you have to go again and on the view box and see again the imaging.
Yes.
Then, then you correlate. Then sometimes you may have to do that shifting of the posterior canal wall by creating channels along the posterior, along with the skin. This I saw Professor Kirtane showing in one of the workshop, and that is a good idea. Luckily, as I said, I never got the chance to do all these things.
Yeah. Okay. There's a lot of appreciation from our friends. Dr. Ramesh Rohiwal, sir from Aurangabad, is a super presentation.
Hello, sir. Good evening.
Yeah. And Dr. Sarvat from Iraq, my friend, he says, you had any experience of CSF gush?
Again, luckily not. Even we were performing a case of cochleovestibular malformation, IP1. Even we performed the cochlear hypoplasia. But we never faced these problems, luckily. Means little bit just pulsations of the perilymph in the scala tympani after opening, but not frank gusher. Even I have performed steppies. We are performing almost 8 steppies every month.
Okay.
And then, even then, I have not seen a single case of steppy surgery with gusher.
Okay. Lucky. You are lucky.
Yes, I am very
lucky. The 4th case was a gusher. I remember this thing, that patient didn't have enlarged vestibular aqueduct or anything. That child had a gusher. Anyway, we waited for some time. It disappeared on its own. Yeah. Okay, sir. Any other question, friends? Dr. Sarvat, he has another question. He is just appreciation. Okay. Yeah. Any other questions, friends? Please let
Whatever,
us know. We have
Dr.
left a
Jalal,
lot of.
even if you feel that this should be clarified here, so I am happy to
Perfect.
share
See, I
my
will tell you, it was such a wonderful, direct, straightforward presentation. They hardly, other than no other information, hardly any questions on this presentation, sir, on this topic. You have done a wonderful job. And Dr. Rohiwal sir says he witnessed 4 gushers in stapes surgery at a stapes surgery carnival at Jaipur. Okay.
Okay.
Yeah, that was organized by Dr. Satish Jain, and
Yes.
okay, there were 4 gushers were there. Yeah, even I haven't experienced. I operated a lot in India, Africa, and Middle Eastern countries, but even I have not come across a gusher yet. Yeah.
Okay.
Yeah. Okay, friends. If no other questions, thank you very much for your participation, and specifically senior friend and a mentor, well-wisher, Dr. Deepak Dalmia sir. Thank you very much for sparing some of your time and sharing your experience and showing those videos. So thank you for being with us, sir, on this occasion. Yeah.
Thank you. Good night.
Good night, sir. Good night, sir. Thank you very much, sir. Okay.